Good evening, everybody. Welcome to this subject seminar on role of surgery in pancreatitis. It is a contentious issue. There are still variable opinions as to when you need to intervene, particularly in acute pancreatitis. It must be said that the stress now is on supportive care rather than on surgery, particularly in acute pancreatitis. It's also true of chronic pancreatitis. So Praveen will go through some initial slides on the introduction to the topic, particularly the anatomy, relevant anatomy that we need to be aware of, some aspects of the severity of the disease, and we also need to know certain terminology. All of those terminology may not be in what Praveen has made slides on, but we will fill in those gaps as and when required. And then discuss on the options of surgery, indications, basic operative steps, and the complications that one can expect. So that would be the plan for today's class. Over to you, Praveen.
Good evening to everyone. Today's topic of discussion is role of surgery in pancreatitis. Before proceeding to our topic, I would like quickly go through the basics of pancreas and pancreatitis. Pancreas is a retroperitoneal organ which is obliquely positioned, and on basis of anatomical relations, it can be divided into head, neck, body, tail, and axillary lobe, that is uncinate process. The main pancreatic duct, that is also known as duct of Fersing, opens into the major duodenal papilla, that is hepatopancreatic papilla of Vater, which is surrounded by the sphincter of Oddi, and there is a minor duodenal papilla, minor axillary pancreatic duct, which opens into the minor duodenal papilla, which is approximately 2 cm proximal to the opening of major duodenal papilla. Coming to arterial supply, the main supply is from the branches of celiac trunk and the superior mesenteric artery. The large portions of pancreas are supplied by the pancreatic branches of splenic artery, that is a branch of celiac trunk. And the head of pancreas has additional blood supply from the superior pancreatic duodenal artery, which is a branch of gastroduodenal artery, which is a terminal branch of common hepatic artery, and the inferior pancreatic duodenal artery, which is a branch of superior mesenteric artery. Coming to venous supply, the drainage is into the hepatic portal system through splenic vein, which drains most of the tail and body of pancreas, and head and neck of pancreas is drained by the superior gastroepiploic vein, which drains into the portal vein, and also by inferior pancreatic duodenal vein, which drains into the superior mesenteric vein. Coming to lymphatic supply, lymphatic drainage usually follows the pancreatic arteries. The body and tail usually drains into the retropancreatic nodes, and superior half of the head and neck drains into the celiac lymph node, while inferior half of the head drains into the superior mesenteric nodes. Pancreas can be divided into exocrine and endocrine, of which exocrine is occupying the major part, which produces around 500 to 800 ml of secretions of different enzymes. And endocrine pancreas consists of among 5 major types of cells that produces hormones. Coming to acute pancreatitis, the usual etiology comprises of biliary tract disease, alcohol, hyperlipidemia, hereditary hypercalcemia, and trauma induced, such as it can be external or surgical or through ERCP, and ischemia such as hypoperfusion, atherosclerotic vasculitis, and in pancreatic duct obstruction such as neoplasms, pancreas divisum, ampullary and duodenal lesions, and cases such as infections, drugs, and idiopathic reasons. Coming to pathophysiology.
One sec.
Yes,
Nikita, can you name 1 or 2 infections that might give rise to pancreatitis? Go back 1 slide, Praveen. Pawan?
Sir, gallstone induced.
I'm talking about infections, man. Infections by viruses are common. Coxsackie adenovirus. Can you name one or two drugs that might cause pancreatitis, Pawan?
Sir, metronidazole.
Very rare. Common ones.
L-aspargine, sir, and isoniazid.
INH might do that, but even much more common are the antiretrovirals. Very common to cause pancreatitis, sometimes very severe pancreatitis. Okay, go on.
Sir,
Yeah,
sir, all this, I don't know, we had a recent class about acute pancreatitis. Only thing we had not discussed was the surgical one.
I specifically, you hadn't joined then, I specifically asked him to skip through this, but obviously when we asked them, they didn't give me the common answers. Okay, anyway, go on. We need to, as I said, focus on the operations for acute and chronic pancreatitis. Please go ahead. Yeah, go on.
My computer had hung, I don't know, it still hung. So that's why I
Okay.
joined on the phone. I tried to see if I could get it.
Yeah,
rectified.
skip this, Praveen. I told you I'd even
Yes, sir.
written to you. I'd written to you to do all this. Okay. Now let
Yes,
us now at this point, I need you to be clear about the terminology. How do you define mild, moderate, and severe pancreatitis?
Sir, in mild pancreatitis, there will be no evidence of organ dysfunction or there
Correct.
will be no local or systemic complications.
All right.
While in moderate pancreatitis, there may be organ dysfunction, but it resolves within 48 hours.
Correct.
Or there may be local or systemic complications without persistent organ failure.
Right.
And in cases of severe, there will be persistent organ failure of single or multiple organs.
Organs are gone, brother. It becomes organs. Yeah.
Yes.
Okay. So the types are interstitial and necrotizing. How do you differentiate between the two? In pathology and in diagnosis.
These are mainly done by CECT imaging, sir.
Correct. Agreed. That's fine. And when do you do it? And at what chronology? What time after the initial episode?
So, early will be the interstitial edematous, which will be mild attack, sir.
Okay.
When it will be followed by the
When will you ask for the CECT?
usually after 72 hours, sir.
Yeah, 3 to 5 days.
Yes.
Okay, not on the day or the first or second day of the pain. All right.
Yes,
You
sir.
talked about local complications. What are the local complications?
So, can I take in next slide or can I explain here?
You can, if you have it in the next slide, you talk about it. Yeah.
Yes.
Take away all this. Yeah.
Yes.
Right.
If the symptoms less than 4 weeks, it will be called as acute.
Right.
And in the interstitial edematous, it can present as acute pancreatic fluid collection.
Yes.
In necrotizing, it can present as acute necrotic collection.
Yes.
And it can be infected and non-infected.
Right.
While coming to chronic, the acute pancreatic fluid collection turns into a pseudocyst.
Right.
And the acute necrotic collections turns into walled-off necrosis, which can also get infected.
What is the difference between pseudocyst and walled-off necrosis?
Sir, in pseudocyst, there will be a pseudocapsule, sir, covering it.
Is that the only thing? Is there anything to do with the solid elements?
Sir, pseudocyst will contain of only fluid, sir. Walled-off
mostly.
necrosis will contain both of solid and fluid debris, sir.
Correct. That is the difference. And that is again differentiated by CECT.
CECT.
Okay.
Sir.
Yes. All right. So what is the pathophysiology of pancreatic ascites? It has a bearing on surgical treatment. We're talking, there's a pseudoaneurysm, we all know, splenic vein thrombosis, we know. What is pancreatic ascites?
Due to the inflammation in the pathophysiology, cytokines are released, sir. It causes vasodilation and
That will
causes
be your acute
third space fluid.
Wait. That is not pancreatic ascites. That is acute pancreatic fluid collection. All right.
Yes, sir.
Local inflammation. But what is pancreatic ascites? What is the underlying pathology in that? Indraja there? Not here. Yeah. Okay. Vinod?
Sir, it is basically ductal communication with the pseudocyst.
Thank you. That is the basic thing. Not the pseudocyst, man, with the ascites, with the peritoneal cavity. pseudocyst also is walled off, right? It is a specific area of collection with a pseudocyst wall, not a true cyst. What's the difference between a true cyst and a pseudocyst?
Epithelialization.
Epithelium. Lack of epithelium makes it pseudocyst. True cyst will have an epithelium.
Epithelium.
That is a limited space, okay? Whereas ascites is all over the peritoneal cavity. There is no limitation. It is not walled off, and there is a rupture of the duct which continues to produce a free leakage of the pancreatic fluid all over the abdomen. Those are the common complications. Now jump straight into the indications for surgery. Go on. Yeah. Go on.
The usual indications are the surgeries to prevent recurrent acute pancreatitis and the surgeries to treat complications of pancreatitis such as abdominal compartment syndrome, infected necrosis, pseudocyst, vascular complications. Coming to surgeries to prevent recurrent pancreatitis, ERCP is indicated usually within 72 hours for severe gallstone pancreatitis, and if there is any symptoms and signs of cholangitis, and if total bilirubin greater than 4 milligrams per DL, or if there is any choledocholitis on the imaging.
If you have choledocholitis sitting, say, high up in the common bile duct, all right, and the pancreatitis is resolving after the first 48 hours. We talked about the symptoms being 48 hours, lasting or organ failure or whatever, lasting 48 hours. What would you do? Would you do an ERCP or not?
We'll do it, sir.
You should not. All right. The two real indications are presence of cholangitis and
Yes, sir.
an impacted stone. Impacted. That's why I specified it is high up in the bile duct. Okay. If you
Okay,
have
sir.
an impacted stone in the ampulla of water with severe pancreatitis persisting for more than 48 hours, then only you do an ERCP. What do you do in ERCP?
We'll be basketing the stone and we'll be placing a biliary. We'll be doing a biliary sphincterotomy or biliary stent placement, sir.
Is removal of stone high up in the CBD more important than, or obstruction of ampulla more important?
Obstruction of ampulla is more
Yeah.
important, sir.
So this basketing can be done if it's easy, but what you need to do is there'll be a stone impacted in the ampulla of water. That has to be released. Okay, because
Yes,
that's
yes.
what gives you pressure in the pancreatic duct. A stone sitting higher up in the CBD does not cause pancreatitis. It causes cholangitis maybe, but not pancreatitis. All right.
Yes,
So
yes, sir.
focus on a papillotomy, minimal intervention, make the hole a little bigger, the ampulla of water, take out the stone, and if you can easily basket the others, you can keep sweeping your basket and this and that. But otherwise, your instrumentation should be to a minimum. Just put a stent to make sure that there is free drainage of the bile and come out. Okay? It's not
sir.
like the goal is not to clear the CBD as you do in obstructive jaundice without pancreatitis. That is the difference that you must appreciate. Okay?
Yes, sir.
Go on. Next one.
Hello, sir.
Yeah.
Sir, if the stone is present in the CBD and it is asymptomatic, will you do ERCP, sir?
No. If the gallbladder is set, if the pancreatitis is settling down, you do not do an ERCP and acute pancreatitis at all. It must be a persistent pancreatitis which lasts more than 48 hours, where you suspect, and the bilirubin more than being 4 means that there is an obstruction to the active obstruction to the bile duct, where you suspect an impacted stone. Only then you do a papillotomy and release that one stone, and do not spend more time and trauma, subject the patient to trauma with instrumentation. That is the point. Okay.
Sir,
Yeah.
so one doubt.
Yeah.
So not in case of patient having acute pancreatitis, generally patient coming with gallstones and stones in the CBD.
Yeah.
Do we still not do ERCP, sir, with obstructive jaundice?
That is a complete, we're not talking about pancreatitis.
Yes, sir.
These are patients who do not have pancreatitis.
Pancreatitis, yes.
All
But
right.
then we go ahead with ERCP, no, sir.
Absolutely.
Yes.
But if they have pancreatitis, the whole game changes.
Yes, sir. Yes.
You deal with the CBD only if there is cholangitis.
Yes, sir. Yes.
Okay, that is the issue.
Okay.
That is the
Okay.
difference. Go on.
And according to American Gastroenterology Association, it recommends cholecystectomy to be performed during the admission for pancreatitis. And if any poor surgical candidates, only the ERCP biliary sphincterotomy or biliary stent placement can be done as an alternative approach.
When would you time this? Recommend cholecystectomy performed during the same admission of pancreatitis.
Yes,
Patient comes to you today with pancreatitis diagnosed. What are your directives to know when to intervene with cholecystectomy?
Usually recommendation within 24 hours, sir, on the day of admission.
With a patient with acute pancreatitis? Anybody?
Yes,
Anybody wants
along
to?
with
Nikita, you talk about 6 days. I missed that in the chat. What did you mean by that?
That was regarding the CCT. We generally ask after 5 days or 6 days time.
Correct.
Sir.
That's fine. Okay. So when would you time what are the indications that you look for when you can do safe laparoscopic or open cholecystectomy?
After resolution of pancreatitis, that is in general after 48 hours.
That is the correct answer. You do not talk about 24 or 48 hours after resolution of pancreatitis. So how do you know the pancreatitis is resolved?
Pain, clinically the pain has come down and
Essentially a clinical diagnosis.
Yes, sir.
Pain has come down, the guarding and rigidity has come down, ileus has disappeared if it was there. It's a soft abdomen. Then you can do it. It may be anywhere between 2, 3, 4 days. So,
Okay.
and if it doesn't settle down after 48, 7 hours, what do you do? We just answered that 5 minutes ago.
ERCP, sir.
Yeah, that means there's
Yes.
there's an impacted stone or some other severe cholangitis. Patient is not settling down. That's when you should do an ERCP. Okay. And if
Yes.
everything settles down and it's a very, very poor surgical candidate, it's a very rare condition. Okay. You do not want another stone coming and impacting and causing pancreatitis. The theory behind this approach is that it is a passage of stone that induces pancreatitis. Okay. Stone comes down from the gallbladder, temporarily blocks the ampulla of water, causes pancreatitis, and is discharged into the duodenum. Okay, but you will have the pancreatitis to run its course 2 to 3 days, depending on what it is, severe or mild. Most of 85% are mild to moderate. Only 15% are severe. So in those severe cases, you look for a possible impacted stone. And if everything has settled down and the patient cannot take an operation, then it may be a long-term solution also. The patient is so poor that you don't want to operate. These are very rare conditions. Today, laparoscopic cholecystectomy is a low stressor as far as surgical, the medical condition is concerned. So you can undertake that fairly safely. Rare instances, just leave a stent, put a stent and come out. You accept that the stone will be there in the gallbladder and maybe even in the bile duct, but you just wait and see if you can improve the patient's medical condition. That's a rare situation, as I said. Most of them will be able to take a laparoscopic cholecystectomy in the same admission as the pancreatitis. Go on.
Intra-abdominal hypertension is defined as persistent increase of intra-abdominal pressure greater than 12 mm of Hg. And if intra-abdominal pressure is greater than 20 mm of Hg, along with the new onset of organ dysfunction, it is called as abdominal compartment syndrome. Usually, initially, it will be managed by nasogastric decompression, percutaneous drainage of ascitic fluid. If the medical management is failed, then the surgical methods of decompression includes midline laparotomy extending from the xiphisternum to the pubis, or it can be by transverse bilateral extended incision below the costal margin to form the full thickness laparostomy, or it can be done by subcutaneous vertical linea alba fasciotomy.
I haven't done any of this. It's a very, very rare indication. It's mentioned in the books. I quite agree. for isolated abdominal compartment syndrome to do surgery in acute pancreatitis is extremely rare. What happens is that the patient will have an acute necrosis, infected necrosis, for example, and you go in and along with that, big ascites, big time ileus, very ill patient. You will have to go in and do a necrosectomy, and you do not close the abdomen at that time. You do only a laparostomy because you may have repeated interventions. And then, when things settle down, you go and close the abdomen. All right. But Ravi, you want to come in and say, have you ever had to do only for
No,
abdominal hypertension?
no. I don't. I think it is mentioned. I think it is much more common with trauma and ruptured aortic aneurysms. Those are the
Yeah,
two
yeah.
commoner conditions where you develop compartment syndrome.
Yeah.
The compartment syndrome is mentioned with acute pancreatitis, no doubt, but it is of the lesser degree, which can be managed, as you said, with conservative measures. And if necrosectomy needs to be done, then we can combine the operation with that, and then, as you said, we can leave the laparostomy open.
Yeah.
Praveen, other
Yes, sir.
thing I wanted to ask you is, if this patient, just going back to the previous scenario of laparoscopic cholecystectomy, if
Yes,
the
sir.
patient is very ill with multi-organ dysfunction needing intensive care management, dialysis, ventilatory support, inotropic support, and the like, acidosis and all that, you have somehow managed to stabilize the patient and do an ERCP and stent. So
Yes,
what
sir.
will you do with such patients? What is the timing of surgery in such patients?
Usually till the patient vitals are stable and pancreatitis resolve, we'll be doing medical management only, sir.
Correct. Then
Conservative management.
get the
And
patient off ICU.
sir,
After the patient is off ICU, off ventilator, off dialysis and inotropic support and everything,
yes,
I
sir.
think still the risk is high. I think in such patients, you will have to accept the risk that there may be further attack of pancreatitis due to stones in the gallbladder, but you are already done a sphincterotomy and stent placed. So you accept that, the risk of it causing any further attacks of pancreatitis is probably less, and wait for a period of about 6 weeks for the risk to settle down and then do the cholecystectomy. I think that is the only scenario which is about 10% of severe pancreatitis, which needs all those supports. Otherwise, all the other things we have discussed is true.
Okay, sir. Yes, sir.
Go on. Yeah.
Go on.
Coming to surgical treatment of infected acute necrotic collections and walled-off necrosis, it can be done by minimally invasive modalities, such as which will be performed in a step-up approach. In first step, it will be done by percutaneous or endoscopic drainage to the left retroperitoneum. And if it failed, then we'll be proceeding to video-assisted retroperitoneal debridement. This is an endoscopic transgastric necrosectomy, which is first step approach. If it failed, then we'll be doing this is the video-assisted retroperitoneal debridement, getting access to the retroperitoneal space. If this minimal modalities fail, then we'll be proceeding to open surgical necrosectomy. There are 4 principles advocated, and they are necrosectomy combined with open packing, planned staged rear laparotomies with repeated lavage, closed continuous lavage of lesser sac and retroperitoneum. 4th one is closed packing. The first 2 methods requires re-laparotomies, and there is a positive correlation between the surgical interventions and morbidity, such as including gastrointestinal fistula, stomach outlet stenosis, incisional hernia, and local bleeding. The other 2, closed continuous and closed packing, usually remove the residual pancreatic necrosis, so there won't be re-laparotomies necessary frequently. The most common adopted
What is
approaches.
closed packing?
Sir?
What is closed packing?
Sir, in closed packing,
Go back one slide.
Sir, will be incision will be closed, sir, and the cavity will be packed with
When will you
gauze
use that?
filled drains, sir.
When will you use this packing? Come on, man, use your
Sir,
common sense. When will you use packing in general?
sir, when there is uncontrolled
Correct. Uncontrolled
Uncontrolled what?
drains,
Uncontrolled what?
uh, drainage and bleeding.
Not
Correct.
drainage, man. If the fluid drains, why are
Fluid
you worried? You want the
drains.
fluid to drain, no? It's not
Yes.
the fluid here, it's blood.
Bleedings, yes, sir.
Hemorrhage.
Bleeding, hemorrhage.
Yes.
That's one of the problems. We talked about pseudoaneurysm formation. That's a real problem with necrosectomy. It can really bleed torrentially, in which case, if you can't control it, if you put stitches, it won't hold. Many times you won't even see where the bleeding is from, in which case you pack it and come.
Yes, sir.
Okay? Yeah.
Yes.
All right. Go on.
Sir, have you just a minute, Praveen?
Yes, sir.
Sir, have you this one? The Professor Neoptolemus from Liverpool.
Yeah.
He advocated this lumbar, the retroperitoneal approach of what he used to call this skunkectomy. It is, it used to be skunk. The necrotic material used to be called skunk. I don't know whether you have actually done any laparoscopy.
I've not done it. It's always
Lumbar.
been transperitoneal anterior approach.
Yeah.
Yeah. Because I felt that it's a very limited space. I mean,
Correct.
many people have done it. I'm not against it. I have no personal experience. It's a limited space. Your view is limited. And so
I feel the drainage is limited. See,
Yeah.
ultimately, you want a free drainage of stuff.
Correct.
And that you can't achieve. I think, the
So,
other thing is the necrotic material block the drain. You'll have
Yeah.
to repeatedly do this procedure.
Yeah.
I think transperitoneal will probably be better.
somehow more comfortable during transperitoneal. Yeah.
Srikanth?
Go ahead. Yeah.
The most commonly adopted approach is a closed lavage of debrided cavity, which was first described of the bigger. In the procedure, the lesser sac will be opened and the greater momentum will be divided as close to the gastroepiploic vessels. 4 catheters are inserted, 2 from the each side, and the tip of catheters are placed at the tail of pancreas, behind a descending colon, at the head of gland, and descending the ascending colon. The lesser sac is closed by suturing greater momentum to the transverse colon for the closed postoperative lavage.
This is the classical thing that I always do. It's not that we have to do it often. Very limited experience. Yeah. Go on.
Coming to surgical treatment of pseudocyst. Pseudocyst is
Just one sec. Before you go,
Yes, sir.
is there anything special about the drains that you use? Even the picture, it looks a little different, as you can see in the picture that you have shown. It's called a sump drain. It's not an ordinary ADK drain that you put.
What is
it?
drainage, man?
What is sump drainage? What is its importance? Why is it special? And what is special about it?
Anybody?
Sir, in order to give wash if required. So
Look at that.
once the
That-
irrigation, sir.
Why is it called sump? You can just use an ordinary catheter. What is sump drainage?
All right. I think you have to go and read up about it. I'll give you just one little hint. There's a lot of necrotic tissue and the catheter can get blocked because of that. So use the phenomenon of what is called a sump drain. I want you guys to read up about it, and then give us the answers in the group. Okay?
Yes, sir.
Yeah, it's not just to give wash. I agree. On one side, you have said 4 catheters. I usually do 2, 1 on each side. One is used for irrigation, the other is to suck the fluid out. Particularly the one that sucks the fluid out must be a sump drain. So you need to tell me what it is. Okay?
Yes, sir.
All right, go on.
Pseudocyst is defined as an encapsulated collection of fluid with a well-defined inflammatory wall, usually outside the pancreas, with or no necrosis. And about 5 to 15% of pancreatitis is complicated by the pseudocyst, and about 50% of severe acute pancreatitis develop pseudocyst. Usually 70% of them resolve spontaneously. Pseudocyst complicated by the infection, or if it is symptomatic pseudocyst, or if the pseudocyst of greater than 6 centimeters and present for more than 6 weeks require intervention.
So what
it
are
can be
just relax, don't, yeah. What are the symptomatic, so what symptoms can it give you?
So, there will be severe continuous abdominal pains, sir.
Okay.
What else?
Anything pancreatic gives you back pain also.
Yes, sir.
What else?
And patient will have loss of appetite, satiety.
Okay. Okay. Why is that?
And due to it will compress the stomach, sir.
Okay.
That space.
Gastric
And
outflow obstruction.
Yes, sir.
Okay.
And patient may have due to it nausea, vomitings.
Yeah. Vomiting. Yes.
Vomiting, sir.
Everybody,
Vomiting, sir.
you know, repeated correction makes us a little frustrated. Okay. I don't know. Just correct yourself.
Multiple vomiting produces vomiting ಅನ್ಸುತ್ತೆ
Yeah, it is still called vomiting only. There is no vomitings. Still vomiting. Multiple also is vomiting. Yeah. Okay.
What else can it cause, man? It is sitting next to the, if it is in the lesser sac, next to the bile duct. You said gastric outlet obstruction. It can
Can
cause.
there be some other obstruction also? Some other tube obstruction? You are practically
It can
giving
be
you the
compressing
answer.
the CBDs. It can
Yes,
compress
it
the
can do.
CBDs, sir.
Yep, it can do that. Yep. Okay. Okay. So these are the symptoms, and if that happens, what are your options?
We can do a percutaneous drainage or
Mhm.
endoscopic drainage or a surgical drainage.
All right.
In the percutaneous transgastric gastric cystogastrectomy, it will be done under imaging guidance.
Yeah.
A double pigtail catheter will be placed, one end in the cystic cavity and another in the gastric lumen. The recurrence rates are less than 15%.
No, but what is the prerequisite for this percutaneous drainage, man? What should be the prerequisite? Praveen, think about it.
Yes, sir.
Anybody else? All right, Ravi, give them the answer.
There should be no ductal communication. If there is ductal communication with the pseudocyst and you drain it percutaneously, you will create a pancreatic fistula.
Pancreatic fistula. Yes, sir.
So that is the prerequisite for you to do. If at all, if there is a ductal communication, then you will have to go for the more internal drainage with either the endoscopic drainage or laparoscopic drainage.
Yes, sir.
Okay, go ahead.
Usually, the endoscopy is a treatment of choice to drain a non-infected pancreatic pseudocyst. We'll be creating connection between the cavity of pseudocyst and to the lumen of GIT. We'll be doing a transpapillary drainage if pseudocyst is in direct contact with pancreatic duct, or a transmural drainage if pseudocyst causes visible impression on the duodenal wall on the imaging. Surgical drainage includes cystogastrostomy, cystojejunectomy, and cystoduodenostomy. In cystogastrostomy, if there is symptomatic or very large pseudocyst of pancreas, which is adherent to the post wall of stomach, that is post wall of stomach forms the anterior wall of the pseudocyst, will be doing the cystogastrostomy. The pseudocyst is visualized or palpated, and the cyst is aspirated. Then we'll be giving incision on the cyst and we'll be opening and we'll be doing the cystogastrostomy, so that cyst drains into the gastric lumen. Coming to cystoduodenostomy, it is indicated when a pseudocyst of head of pancreas is anatomically placed so that only the cystoduodenum is possible. Here, this is the same procedure where pseudocyst is visualized, palpated, and will be aspirating the cyst, will be opening and forming a side-to-side cystoduodenostomy. A cystojejunectomy is indicated when a pseudocyst is not adhering to the posterior gastric wall in any location in pancreas, and the pseudocyst bulges to the transverse mesocolon. Here, the cyst is aspirated and jejunum is transected with stapler 20 centimeter from the ligament of Trees, and the distal end is overseen and brought up to the cyst as ruling, and a cystojejunectomy is done. And a proximal jejunum is anastomored 60 centimeters from the ruin limb.
Why is that 60 centimeters?
So there won't be any reflex.
Food should not get into
Food
the cyst.
reflex. Yes, sir.
All right. 60 is pretty generous. Anywhere between 30 and 40 should be quite enough. Why are you worried? Why can't it be 120 centimeters? Even more safe than 60?
I don't know exactly.
You don't know? Think. Anybody else? Nikita? Lot of surgery is common sense. Correct. That part of the bowel is not going to absorb anything. The food doesn't go there. Okay.
Yes, sir.
Yeah. Food and the digestive juices don't go there. So we want to keep it to a minimum where absorption is not adversely affected, but at the same time, reflux of food into the cyst does not occur. So that
Yes, sir.
distance is probably 30 to 40 centimeters. You mentioned 60. I wouldn't contest that strongly. Go on.
Praveen, did you talk about infected pancreatic necrosis?
Yes, sir.
How do you diagnose it? How do you manage it?
Management I have described in this only, sir.
No, you haven't. You haven't
necrosis is
actually
different.
done.
Infected pancreatic necrosis. Specific thing. How do you diagnose on the CT? What is the difference between a sterile necrosis and an infected necrosis? Anybody?
Presence of air.
Correct. Presence
And
of
anything
air.
else? Presence of air in your CT? Anything else?
Clinically fever with rise in
Yeah.
tears.
Septic picture, presence of air. What else do you do? CT directed aspiration of the fluid and its culture. Okay. These are the three things that tell you that there is a infected necrosis. When your antenna must go, because that's when they can go into multi-organ failure. So what do? Conservatively manage them for a few days and watch how well they get better. If they do not get better, there is no fixed time as to 24, 48, 72 or things like that, depending on the patient's condition. If they're not getting better with high-end antibiotics, then you will have to intervene and do a necrosectomy. Necrosectomy can be done in all the methods in which you mentioned. What antibiotics would you use in these patients? Nikita?
Okay.
Carbapenems.
What antibiotic would you use for these patients? It's always high-end antibiotics. All right. Imipenem, carbapenems as they call it, meropenem, imipenem, in that, or cefepime, the highest levels of cephalosporins. Those are the kinds of antibiotics you have to use in these patients.
And
would you use
wait for the culture? Yeah.
Wait for the culture and make it specific. Would you use antibiotics in all cases of pancreatitis?
No, sir.
No.
In general, we don't.
Correct. You do not use it in pancreatitis. Okay. Anything else, Ravi, that you want to?
No, sir. I think.
All right. Niranjan, are you there? I don't know. He's there. Any comments, Niranjan, so far? Shrikant?
Nothing, sir, nothing.
Nothing. Go ahead. Chronic pancreatitis now.
A chronic pancreatitis is a persistent, long-standing inflammation of pancreas, which results in permanent structural damage marked by fibrosis and ductal strictures, leading to an irreversible decrease in both exocrine and endocrine pancreatic functions.
Somebody asked a very simple question the other day. What is the difference between acute pancreatitis and chronic pancreatitis?
Dr. Pooja Hari, yeah.
Yeah. No, he's right. What he said was quite correct.
Correct, yes.
Yeah. That's why I'm asking it again. I don't know if you're if you're listening to it or not.
In acute pancreatitis, the inflammation of normal pancreas, sir.
Okay.
And chronic pancreatitis is repeated inflammation of the pathological pancreas, fibrous pancreas.
Point is that after acute pancreatitis, the pancreas can come back to normal.
Yes, sir.
Okay. When it doesn't come back to normal, or when whatever disease leaves you with a fibrotic pancreas, then that becomes chronic pancreatitis. Okay.
Yes, sir.
So, yeah. So, and after the episode, if you do not have a normal pancreas, then you can call it a chronic pancreatitis. Okay, go on.
And the etiology can be classified under Tigaro system. It includes toxic metabolics such as alcoholic, tobacco smoking, hypercalcemia, hyperlipidemia, medications and toxins, and idiopathic and genetic such as trypsinogen gene, PRSS1 mutation, CFTR gene mutation, SPINK1 mutation, and autoimmune and recurrent severe acute.
Skip to surgical procedures.
Yes. The drainage options, if there is any chronic cirrhosis, it can be done with cystogeginostomy, lateral pancreaticojejunostomy, caudal drainage, or if to alleviate the pain, if resection is required, then it can be done by the pancreaticoduodenectomy, a duodenum preserving pancreatic head resection, V-shaped excision, segmental resection, distal or total pancreatectomy. Coming to individual one, Pisto procedure, which is a longitudinal pancreaticojejunostomy. It is a treatment of choice in patients with chronic pancreatitis or if there is dilated pancreatic duct with no inflammatory mass. Here, a opening is made along the surface of pancreas from the head till to the tail, and a Roux-en-Y jejunostomy is attached to the side of pancreas. The morbidity mortality rate is about 1%, and pain relief is seen in about 80% of cases.
All right. So, what should you need to know a little more about this. What do you think should be the size of you said dilated pancreatic duct. What should be the size before you actually operate on it? Anybody else has read about this?
Yes, sir.
7 mm.
Sorry?
7 mm, greater than 7 mm.
Yeah, you're right. It used to be 10 mm until quite recently, a few years ago. Now they have said even if it is 7 mm, it should be okay. Okay, why is it that you have to lay the whole length of the gland duct open? You have shown in the picture also, nearly the whole length of the duct is open. Why?
What is it classically described as? Which is why you have to open the whole thing.
Something of lake appearance.
Chains and lake.
Huh?
Chain of lake appearance.
A chain of lake, okay?
Yeah.
There are strictures, yeah? There are strictures at points. So if you sort of open it only near the head, for example, you can still have hypertension and blockage of the duct elsewhere. So you have to lay the whole thing open and do a lateral pancreaticojejunostomy. Okay. So
Yes,
you mentioned about 80% of cases they get relief, which is correct. Is there a limitation on the duration also? Is it forever that they get better? Or does the disease does it have a better upper hand in time to come? If the relief is there for 7 to 10 years, you're a lucky man. Many times in 5 to 6 years, the pain can come back again because it is a progressive disease.
yes.
All right. What does it do to the endocrine function?
Sir,
If
there
the
will
patient
be
is
loss of-
diabetic, are they going to get better or not with this procedure? They're not going to get
No,
better.
sir. No,
What
sir.
does it do to the exocrine function? Is it going to get better or not?
There will be betterments.
It may or may not.
Yeah.
They may still need pancreatic replacement. So the primary indication for operation in chronic pancreatitis is relief of pain. They may get better with exocrine function. They will not get better with endocrine function. And it is good for you to give them exocrine replacement and endocrine and insulin if required forever. Okay,
Yes,
so
sir.
these are
Yes.
things you must know before you offer surgery to these patients. Go on.
This will be the Frey procedure, in which will be accessing the entire head of pancreas, including the major and minor pancreatic ducts, and with preservation of posterior pancreatic head and pancreatic neck. Additionally, the main pancreatic duct is opened and a Roux-en-Y limb is brought up to a complete pancreatic or jejunectomy here. Postoperative morbidity in Frey's procedure ranges from 7.5 to 39%, with mortality ranging from 0% to 2.4%. A study showed that around 90% of patients had a full alleviation of pain by the Frey procedure.
Now, the other important here, this is the head coring that is done. Okay, in
Yes.
few stores, you are mostly restricting your opening up of the duct to a point to the left of the head of the pancreas. Okay, and if you have a lot of calcification, a lot of stones in the side branches of the head of the pancreas, you cannot individually lay them open. So you do what's called a head coring. Take away the pancreatic tissue, leave the whole thing as a cavity there, as a kind of a sink, as a kind of an open space. All right, and then you put a loop of jejunum onto it. That's a Frey's procedure. I've done it on occasion. And this is important if you have multiple calcifications in the head of the pancreas. What you must remember is that the outcome of any of these drainage procedure, not talking about resection procedure, drainage procedure is limited if you have pancreatic parenchymal calcification. Whereas they work very well if you have a dilated duct with stones in the duct, which can be cleared after you lay open the duct. Understand? So limited results if there is parenchymal calcification, and if there is a lot of that and less of ductal stones, think of resection procedures rather than drainage procedures. Okay?
Yes, sir.
Right, go on.
Sir, it is especially useful in the South Indian version of the chronic pancreatitis, where,
Right.
as you said, it's mostly ductal stones and ductal dilatation.
Yeah.
This, the pancreatitis related to cassava and
Yeah.
other things.
Kerala.
Kerala. So
Yeah,
there,
yeah.
I think this Pusto's procedure or Frey's procedure works very well.
Yeah. Go on.
Morbidity is up to 39%. What are the morbidities?
Go
There will
on.
be a chance of pancreatic hemorrhage, sir,
Okay.
and there will be
A leak.
pancreatic fistula,
A leak.
bile leak, yes, sir, leak.
Okay. Bile leak is a little
Bile
unusual.
leak.
Chyle leaks.
Chyle also is unusual. It's pancreatic leak.
Leak. Yes, sir.
Pancreatic leak.
Pancreatic leak.
Fistula.
Okay, and a fistula
Yes, sir. Yes, sir.
coming from there. All right. Yeah, go on.
And the next procedure is the biggest procedure, which is also known as a duodenum preserving pancreatic head resection. Here, it is done by preserving the posterior branch of gastroduodenal artery, and there will be resection of neck and head of pancreas, especially the area superimposing the portal vein and superior mesenteric vein, with the effort to preserve pancreatic tissue present at innermost part of duodenum. A study showed that around 91.7% of patients had reported pain-free, with a median of 5.7 years.
Got that? So please understand that it is not a permanent cure. You're buying a few years of comfort for the patient. Go on.
What is the specific indication for this, sir?
You want to take that, Praveen, or anybody else before I answer?
Sir has already answered
sir.
that question.
Yeah. Parenchymal calcification, Shrikant. If it's not primarily a ductal dilatation, but rather a parenchymal disease, then even Frey's procedure will not help because it's not a dilated duct. So you need to have a dilated duct and for these drainage procedures. So this is it is a resection procedure, but not an extensive resection like a Whipple's or a distal pancreatectomy. Yeah.
Yes.
And other important thing is considered to be less morbid when there is no duodenal resection. Because here you see there is only a pancreatico-jejunal anastomosis. There isn't any bowel or bile duct anastomosis. So it's supposedly less morbid than a Whipple's. So you preserve a rim of the head of the pancreas and stick a bit of jejunum onto it so that you're not, and the blood supply is maintained by preserving the pancreatico-duodenal artery. That is the principle. I have not done it. But that's the principle. Yeah. Go on.
Next will be the distal pancreatectomy. It is indicated in cases such as distal pancreatic disease and simultaneous small duct diameter, and if there is failed Pfister procedure, and if there is any pseudoaneurysm in the pancreatic tail or portal hypertension secondary to small duct disease, or if there is any suspicion of malignancy in the pancreatic tail. It is associated with risk of symptomatic recurrence with long-term relief only in 60% of patients, and there may be chance of complete pancreatectomy needed in about 13% of patients. Approximately half of the patients will develop both exocrine and endocrine insufficiency due to the distal pancreatectomy.
All right. Yeah.
And in V-shaped excision, it is done as a treatment for a rare subgroup of chronic pancreatitis, which is characterized by a small pancreatic main duct, that is also known as small duct disease, in which there will be non-dilated Witzing duct with narrowing. It is also termed as pseudo-vanishing. In this, there will be a longitudinal deep and a wide V-shaped excision of ventral aspect of pancreas with tip of V located at the main pancreatic duct, and longitudinal pancreatic jejunostomy with a Roux Y lupus made at it.
Practically, you are excising a bit of the anterior part of the pancreas down to the duct to make it a bigger duct. If you have small ducts, as we said, the generally accepted figure now is 7 mm. If you have a 3 or 4 mm duct, I probably wouldn't do any surgery, but in the enthusiasts push this procedure, you can make it wider by excising a rim of the anterior part of the pancreas along the duct and doing this anastomosis. Yeah. Go on.
We know diagram of this one. V-shaped.
Yeah, it hasn't put a diagram.
No, sir.
Okay.
No diagram.
Yeah. But it is available in the books. Yeah. Yeah.
Yes, sir.
Yeah, go on.
Coming to Whipple procedure or pancreatico-duodenectomy, it is almost exclusively now used for only for the resectable pancreatical ductal adenocarcinosis rather than for the chronic pancreatitis, because it can be effective in treatment of pain, but there is significant long-term both morbidity and complications.
Just Whipple's for pure chronic pancreatitis is very, very rare. Disease restricted to the head and where you cannot rule out malignancy, for example. In 10% of cases, even with the presently available sophisticated investigations, including endoscopic ultrasound and targeted cytology and things like that, in 10% of cases, you still cannot rule out a malignancy. In those cases, you do a Whipple's procedure, and you'll be very happy when the patient gets well and you get your result back as chronic pancreatitis only with no adenocarcinoma. All right, that's a rare situation and indication for Whipple's in chronic pancreatitis.
So previously, I think, as you said, now the diagnostic modalities have got so better that these scenarios, as you said, come down to a significant number. But rather uncharitably, people used to say that the results of Whipple's was good because he operated mostly on chronic pancreatitis,
not on
masquerading as
carcinoma.
malignancy, and the ones which he did well are the patients with chronic pancreatitis rather than malignancy.
That's true. Okay, go on.
Coming to complications of the surgeries, it might be a post-pancreatectomy hemorrhage, pancreatic fistula, delayed gastric emptying, portomesenteric venous thrombosis, anastomotic strictures, biliary leakage, chyle leak. Coming to post-operative pancreatic fistula, it is defined as any drain fluid on or after post-operative day 3 with amylase level at least 3 times upper limit of normal, and the condition should be clinically relevant. It is divided into 2 degrees, group B and groups grade B and grade C. In grade B, it requires therapeutic interventions including antibiotics, enteral or parenteral nutrition, blood transfusion, or any intervention but not the surgical procedure. In grade C, it includes the most life-threatening conditions, and there are single or multiple organ failure develops, and the surgical reoperation is needed in these cases. And any case in drain fluid amylase that does not lead to clinically relevant manifestation, it is called as biochemical leak. And it is also same for the cases where surgical drain remains in place after discharge, but it is not lasting more than 3 weeks after surgery. Coming to post-pancreatectomy hemorrhage, it is graded into mild and severe by the International Society Group of Pancreatic Surgery. In mild, there will be decrease in hemoglobin concentration by less than 3 grams, while severe, there is more than 3 grams of decrease. And in mild, there may not be need for any invasive treatment, while in severe, they require invasive treatment. And it can be classified into grade A, grade B, grade C based on the early occurrence of hemorrhage, late, based on the clinical conditions. In grade A, it will be mild, intraluminal or extraluminal, and the patient is in vitals, patient vitals are stable and there won't be any therapeutic consequences. In grade B, there will be severe hemorrhage and patient will have intermediate life-threatening conditions and may require transfusion of fluid, blood, or intermittent ICU management or therapeutic endoscopy or embolization. And in grade C patients, there will be severely impaired and life-threatening condition and requires localization of bleeding, angiography, or embolization through endoscopy, or they may require relaparotomy also.
What would be your first choice of stopping the bleeding if it is some intervention is required?
So, we'll be starting with medical management, sir.
All right, that is true, but as I said, intervention required. Sorry, anticoagulants, sir.
No, sir.
Don't get it. I'm not. See, what are the interventions that you have mentioned here?
So,
just read what is on the screen.
Endoscopy, therapeutic endoscopy, and endoscopic embolization.
Yeah.
Or
it is not endoscopic embolization.
Angiographic and
angiographic embolization and relaparotomy. Which would be the first one that you would do?
So repeating therapeutic endoscopy, sir.
Very likely to be embolization. All right, because because you mentioned all these procedures. Where will you do the endoscopy on post-op day 2 or 3? Understand?
Yes, sir.
Yeah, it's very difficult to find out. You know, you think of yourself, think of a Pugh's Toes or a Beggar's or Phrase. Where is endoscopy going to take you? Nowhere.
Yes,
so the first choice is arteriography, angiography, detect the site of hemorrhage, and embolize it. If that doesn't work, then you can see if that area is reachable by an endoscopy. Very likely it is not. Then you may have to go in. But remember, one of the first things to do is to consider an angiogram and embolization. All right. Any other comments? Srikanth, I think you're saying something.
What is the common source of severe bleeding which requires embolization?
Superior mesenteric artery.
What are the blood vessels close to the body of the pancreas, close to the head of the pancreas?
Head of pancreas, it will be superior pancreaticoduodenal artery.
Pancreaticoduodenal.
Artery. Yes, sir.
What would be near the body of the pancreas?
And there are branches of the splenic artery.
Splenic artery. So always mention gastroduodenal, pancreatic duodenal, and splenic arteries or its immediate branches as the major sources of bleeding, anything related to the pancreas. Okay?
Yes, sir.
All
Yes,
right.
sir.
Go on.
Delayed gastric emptying, it is defined as need for maintenance of nasogastric tube for more than 3 postoperative days, or there may be need to reinsert the nasogastric tube for persistent vomiting after postoperative day 3. And if there is inability to tolerate a soft diet, solid diet on or after postoperative day, it might be considered as delayed gastric emptying. It is graded into A, B, C according to the requirement of the nasogastric tube and reinsertion.
Praveen,
All right.
sir has already corrected you many times. It is, internationally accepted NASO, not NASO. Okay, so it's
Okay, sir.
nasogastric tube.
Okay,
Okay.
sir.
Yeah. Why don't you guys, just take up the corrections and, consciously use it?
Yes,
Okay,
sir.
carry on.
We are not saying this to put you down, but
Then and
imagine,
there you write down the mistake and then correct it.
imagine
Right,
yourself
you'll forget.
talking in front of 300 people in an international forum. We are not looking at Tyagaraja Nagar and API Bhavana. You understand? We are
Yes,
looking
sir.
at
Yes.
national and international level of presentation. And
Your
you
goal
must,
should be that.
you must have good diction. You must learn, apart from learning surgery, you must learn good English also. Try and be as correct as possible. Okay?
Yes,
All
sir.
right, go on.
I'll
go
do
on.
it.
So all of you, it's not meant to pull you down. And I'm not saying there is anything great if you know English, and there is not something inferior if you do not know English. That's not the argument. That's not the point. But whether you like it or not, the international language of communication is English. And so if you want to make a good impression at an international level, please learn to speak good English. Okay, go on.
Coming to biliary leakage, it can be defined as a drain fluid with bilirubin concentration more than 3 times the serum bilirubin on or after postoperative day 3, or if there is presence of biliary collection that requires puncture or re-laparotomy. It is also graded into grade A, grade B, grade C based on the clinical conditions and clinical symptoms. In grade A, there will be no persistent drainage for greater than 1 week, and there is no need for diagnostic assessment or radiological imaging. In grade B, patient will be moderately impaired and he may have abdominal pain or signs of infection, and he may require there will be persistent drainage for more than 1 week, and he requires a diagnostic assessment and radiological imaging, and there will be increased prolonged stay of hospital stay. In grade C, patient will be severely impaired and there will be life-threatening conditions with single or multiple organ failure, or there may be biliary peritonitis also, and patient requests diagnostic assessment, radiological imaging, and probably re-laparotomy, and there will be prolonged hospital stay.
See, here it usually happens after Whipples, but biliary leakage after Puestos and things like that are extremely rare. Okay.
Yes,
But yeah, most of the time, as I said, it's a hepatobiliary and pancreatic surgery. The pancreatic surgery we're talking about is Whipples. When you're doing a head coring, if you're very aggressive and go through the posterior wall of the pancreas, which you're supposed to avoid, okay,
Yes,
then
sir.
also you can have a biliary leak, apart from a pancreatic leak, of course. But that is again extremely rare. Go on.
Kylic can be defined as the presence of lipid-rich milky fluid from the drains after postoperative day 3, and it occurs in 4 to 10% of patients undergoing pancreatic resections. And it can also be graded as A, B, C based on the
Don't read that. It's
Okay,
no,
sir.
yeah, go on. Yeah. So depending on the severity,
severity.
it is
Yes.
graded, and most of the time, bowel rest will help seal it. And if it doesn't seal, you'll have to go in, look at where it is leaking and stitch up that. And what would be the organ that is most commonly involved? Or what would be the source of this chyle leak?
In the pancreas.
where is the chyle coming from the pancreas? These things will not happen in drainage procedures. It happens in resections, particularly the head of the pancreas. And what is the structure that is commonly affected? What is behind the head of the pancreas that can drain chyle?
Lymphatic vessel.
What lymphatic vessel? I know lymphatic.
Sir.
Nikita?
Thoracic duct, sir.
Thoracic duct in the abdomen.
Cisterna chyli.
Thank you. Cisterna chyli, that is the main
Yes, sir.
dilatation of, that is the one that gets the chyle or lymphatic fluid from all of the GI tract, all the small bowel, right? And cisterna
yes, sir.
chyli is just behind the head of the pancreas. So when you are aggressive and you can damage it and you can have a chyle leak, it can lead to a tremendous loss of fluid and proteins. Okay, so you should be very careful about malnutrition in a patient with a major chyle leak. All right, go on.
Yes, sir.
Yeah.
That's all.
That's all. So you must have a thank you slide in the end.
Thank you, sir.
Yeah, you must say
I
thank
had
you
it,
also.
sir.
You
Yes,
had
sir.
it, but
Thank
it
you,
went
sir.
missing. All right.
Yes.
Audience should tell thank you.
All right. Any questions from the students first? Questions or comments? From the registrars? Okay. Comments from Niranjan, if you're there, Niranjan?
Sir, nothing, sir. It was good.
Okay. Srikanth,
Nothing.
Ravi?
I think it was well structured. I think that is the what comes across, very well structured. It's when nicely presented with diagrams and the complications. I think that is, the very good part of it was the post-operative complication. Very well explained. I think by and large you've done a good job.
Yeah, I agree.
Thank
I
you, sir.
think it was a well-structured, covered the topic very well from the DNB point of view, MS point of view. Presentation was pretty good as well. Okay, the little corrections that we made in your English and pronunciation and words like that has to be taken in the correct perspective,
Yes, sir.
in the right sense, and you should not feel bad about it. And I
Yes,
think
I'll
a
improve
few
it, sir.
more presentations like this with diligent commitment will make you a very good presenter. Okay. Thank
sir.
you,
Thank you,
friends, and good night. I'll close the meeting.
Good night, sir.
Thank you.
Good night, sir.